While invasive arterial cannulation remains the clinical gold standard in acute care setting, non-invasive blood pressure, that is NIBP monitoring, relies on applying external counter pressure to assess arterial wall dynamics. The underlying physics and signal processing vary significantly depending on the technique used. The oscillometric method, automated. This is the standard mechanism for modern automated sphygmomanometers. Rather than relying on acoustic signals, it analyzes pressure variations within the cuff bladder caused by arterial volume changes during the cardiac cycle. As the cuff inflates to a suprasystolic pressure, the underlying artery is completely occluded. As the pneumatic valve gradually bleeds pressure, blood begins to flow, creating volume pulsations. These pulsations transfer mechanical energy to the cuff, registered by a pressure transducer as oscillations. The point of maximum oscillation amplitude corresponds precisely to the mean arterial pressure. The device measures this value directly, making it the most accurate data point in an automated reading. Unlike manual auscultation, automated cuffs do not measure systolic and diastolic blood pressure directly. They are calculated empirically using manufacturer-specific algorithms. Typically, systolic BP is identified on the ascending curve where the oscillation amplitude is approximately 50% of the peak, and diastolic blood pressure is identified on the descending curve at roughly 80% of the peak. Please note that while lowering pressure in the cuff, initial amplitude of oscillation is low and MAP is reached with maximum amplitude of oscillation. Initial fall is such a way that when it reaches 80% of peak oscillation, it will correspond to diastolic pressure. Modern automated devices use proprietary, highly guarded algorithms that may adjust these ratios dynamically based on the shape of the individual patient's pulse envelope, heart rate, and arterial stiffness. The traditional manual technique relies on acoustic detection of turbulent blood flow. When cuff pressure drops below systolic pressure, blood forcefully jets through the partially compressed artery during systole. This high-velocity jet creates turbulent flow, vibrating the arterial walls and generating the acoustic frequencies known as Korotkoff sounds. Phase 1, the first tapping sound, marks systolic blood pressure. As cuff pressure drops below diastolic pressure, the vessel remains fully open throughout the cardiac cycle, restoring silent laminar flow, that is phase 5. Continuous NIBP, the volume clamp method, used for continuous beat-to-beat monitoring, often in critical care or autonomic testing like the tilt table test. This method operates on a high-speed electromechanical servo control loop. An infrared photoplethysmograph, like the one seen in your pulse oximeter, integrated into a finger cuff, continuously monitors arterial blood volume. A proportional pneumatic valve rapidly adjusts the cuff pressure at a frequency of up to 1000 times per second to keep the arterial volume exactly constant, clamped at a set point. Because the external cuff pressure constantly mirrors the internal arterial pressure to prevent the vessel wall from expanding or contracting, the pneumatic pressure waveform recorded by the cuff effectively reproduces the intra-arterial pressure waveform. Continuous NIBP by applanation tonometry. This technique derives continuous pressure waveforms by applying targeted mechanical force to a superficial artery, typically the radial artery, which is supported by bone. It relies on the Imbert-Fick principle, which states that the pressure inside an ideal thin-walled sphere is equal to the force required to flatten a specific surface area, expressed as P is equal to F by A. A high-fidelity transducer array applies force to flatten, that is applanate, the arterial wall. When the wall is perfectly flattened, the tangential forces of the vessel are neutralized, allowing the sensor to directly measure the intra-arterial pulse pressure. This peripheral waveform is often passed through a generalized transfer function to estimate central aortic pressure.